Hello, I'm Ramon Johnson, President of the American Board of Emergency Medicine and a practicing physician in Mission Viejo, California. I want to address a topic that resonates deeply with all of us: the mental well being of emergency physicians. Our profession is as rewarding as it is challenging. The rapid pace, the high stress scenarios, and the emotional weight we carry can take their toll. Acknowledging that our profession profoundly impacts us is far from a sign of weakness. It's a testament to our resilience that we're willing to seek help when needed. The Stop the Stigma campaign serves as a poignant reminder that at our core, we are human beings first and physicians second. It's normal to feel overwhelmed on occasion. What truly matters is how we confront these feelings head on. Nurturing our mental well-being necessitates practicing self-care. Discover activities that rejuvenate you, lean on your support network, and deliberately set aside time for yourself. By tending to our own needs, we fortify our capacity to provide exceptional care to our patients. So let's initiate a shift by having conversations about mental health commonplace within our circles. Sharing our personal experiences can illuminate the fact that we're never isolated on this journey. Through mutual support and the acknowledgement of our shared struggles, we can cultivate an atmosphere where seeking assistance is not only accepted, but encouraged. As emergency physicians, we have dedicated our lives to serving others. Let's extend that same level of care to ourselves. Let's stop the stigma.
Hey everyone, long time no see. I'm so excited to see so many familiar names, faces, and would-be faces as you're trying to turn on your camera if you want. If not, completely okay if you don't.
All right. Well, I know that we probably are going to have people joining us throughout the next few minutes, but I think to get our conversation started, I can go ahead and first introduce myself and then why we are here. But I'm Amanda Deutsch. Thank you for joining us. I am the subcommittee chair of Stop the Stigma EM, which is amazing to say that we have a whole committee now, as this is our second month-long annual effort that we are doing. So thank you, and thank you for joining us to kick off this year's Stop the Stigma EM campaign. It is incredibly important to us that we have had such significant support throughout the community of all these incredible groups joining us. And for this week, we are sponsored specifically by SAM, ABEM, AACEM, so the Association of Chairs, AAEP, and the Coalition of Psychiatry Emergencies as well. So a stunning group to kick off the week and the month. And in this Zoom, we are doing Mental Health Matters, normalizing discussions on emergency physician mental health and well-being. And I'm so excited for the incredible panel we have. And I would actually like if the 5 speakers don't mind introducing themselves, since I want to make sure everyone knows who you are, and then we'll go ahead and start the conversation.
All right, I'll jump in first. My name's Tony. I'm a psychiatrist in Milwaukee, Wisconsin, predominantly focused on emergency psychiatric work. I'm fortunate enough to be the immediate past president for AAEP, and I consider it an honor to be here. I really appreciate you guys having a space for this conversation and looking forward to contribute in whatever way I can.
Okay, I'll jump in next. I'm Lisa Wolf. I am the Director of Emergency Nursing Research at the ENA and the incoming chair of the Coalition of Psychiatric Emergencies. And I have done considerable work on PTSD, specifically in emergency nursing.
I can go next. I'm Junji Takashita. I'm the current president of AAEP. I'm also a clinical professor of psychiatry at the University of Hawaii. And again, thank you for the invitation for this program.
I'm Les Sun. I'm really glad to see that we're focusing on our own. And so that's a great evolution in our field. I'm a professor of emergency medicine and psychiatry, although an emergency physician. And I focused on behavioral emergencies for many years. I was past president of both Coalition for Psychiatric Emergencies and as well as the course director for the national update on behavioral emergencies. So thank you for having me.
I guess I'll go next. So I'm Karen Lummel. I'm actually the chair of the Department of Psychiatry here at Prisma Health and University of South Carolina in Greenville. But I have actually been a psychiatrist, adult and child psychiatrist longer than I've been an emergency physician. So I practice in all 3 areas. Depends on the day. So excited to be here and to be covering this topic.
I love it. Well, thank you. I want to make sure that everyone knows that we do want this to be a discussion. So if you have questions, please put them in the chat, interrupt, do whatever you'd like so that we get you to be involved. And if there's anything ever that you feel is more sensitive and you don't want it to be recorded, we are happy to pause and stop the recording so that everyone has the space to feel like they can speak about whatever they would like to. And I think with that, I will start with our kind of first question to get everyone the ball rolling and get everyone speaking of how do we begin to really talk about our own mental health and well-being with our colleagues, let alone sometimes with our leadership, when we may already feel that it's vulnerable to talk about it, and that sometimes it feels like there's going to be a lot of stigma if we even try to speak to someone about what we're going through.
I think you've got a two-parter there, kind of. I think there's and I'm so glad you're addressing stigma because it probably is the biggest rate limiting element. One would be on people that already present to our workforce with illnesses, that they feel stigmatized again, kind of feeling forced to keep it hidden or from their colleagues for fear that their competence or their ability to be trusted in an emergency would be kind of accusatory. I think that's one group that I think we've actually done a decent job of trying to reach out to, and people have changed applications and licensing things. I think the one thing we haven't steered quite as much into would be my second thought, which is even if you theoretically don't have some sort of illness that you're aware of or ever been diagnosed with, this is really hard work. This is really traumatizing work. And it's perfectly understandable to come in without having any of those feelings. And after doing this work for a while, particularly in our current environment, for it to hit you very heavy. And so I think oftentimes I've talked to people who say, well, I don't have a doctor, I don't see a therapist. And I said, yeah, but you do this work and you do it well and you do it passionately and you take a little bit home as you often do. And this can all add up over time. And I think kind of leaning into that will get people to understand this doesn't have to be a DSM diagnosis per se. This can be an occupational hazard, for lack of a better term. And I think the more people hear that, the more they're comfortable talking about it, because we do take pride in the hard jobs that we do and what happens from doing a hard job. So therefore, you turn pride into communication.
Right. I would agree with that. And I would add from the work that we do with emergency nurses, who also do like very emotionally traumatizing work, is that people, what the participants in our study told us is that they carry this, and I'm sure their physician colleagues do as well, and are afraid of being seen as less competent, less strong, less able. And so they will literally, they were like, I will literally go kill myself in the bathroom after my shift, then go and ask for help. Like, this is the environment. Like, emergency medicine is like the quienes más macho kind of attitude, right? Like, who's tougher, who never runs, who all these other things, right, are equally applicable, I think, between nurses and physicians. And our study showed that 75% of our participants were carrying around like clinically diagnosable levels of secondary traumatic stress. And that really affects people's ability to work, right? Because you have all those intrusive thoughts. You don't want to go into that room. You don't want to take care of that patient. But it also transfers to home, because in order to do this work well, you have to compartmentalize. You have to put all of it in boxes so that, but then that you get so good at it that it transfers, like you go home and you can't talk to anybody, right? You can't react, you can't respond to anything because you're so deadened to what's happening so that you can do your job. And that's something I think that is broadly.
I think there's another way we can also look at this as a leader. How can I pull in my staff and talk to them on this level? And what I've done, especially during COVID, was I would meet with each of my staff members every 6 months with 3 questions. Basically, how are things going? Second is, can we do anything to improve patient care and throughput and those kind of things? And then the third is, are there any personal issues or things that I can help with? And it's kind of the edge of, you don't want to ask too much, but you want to open the door. And so that's my way to open the door.
Yeah, I think one of the things that's occurred now is the term burnout is used much more so. And I think the stigma of that term is a lot less than mental illness, although sometimes it's the same thing. And it's hard to distinguish burnout versus major depression. But I think it doesn't really matter what we call it, if we can manage it and treat it. because the consequence of all this is really the same. It's not good. That I was just thinking about, I've been a physician for a while. I know three physicians personally who've died from suicide, and two were in mental health, and one was internal medicine. But for none of them, there was anything overt that they were in trouble. So we don't do a very good job of taking care of ourselves.
I see what Anish wrote in the chat, and I think it's kind of relevant to this. He said he really appreciates the question you posed to your team, but how many would actually maybe take you up on this or speak about it when you ask that, is the way that I'm taking what Anish wrote.
All right, I'll answer that question. You're right. It has not always been fruitful. So, but some have expressed their issues and their concerns. I mean, one of them talked about I'm burned out and I'm having issues with burnout. And so then we looked at what resources can we take her off the clinical schedule or put her in a different environment. So there were a few, but they were a minority. And I think that part of this is, do you develop a rapport with your faculty members or staff members? And the second is, do they feel comfortable expressing those private issues? And I think that's a harder, I mean, that's why we're here today to talk about the stigma and how can they be more comfortable talking to their boss, so to speak. It's different when there is performance problems and there's an obligation to not only talk to them about it, ask them. My first question is usually, do you have a problem with drugs or alcohol, or is there something going on in your family to help support them when I know what's going on? But that's not the run-of-the-mill folk staff that I would be talking to.
Do you think that so we're necessarily, this has to be a discussion about individuals, right? But is there, I kind of feel like when you broaden the perspective to systemic issues, like people are less stigmatized when they feel like it's not just me that can't cope, right? Like the system is set up for us to be traumatized, to be stressed, to be burnt out, right? In terms of the training requirements of physicians, in terms of the overtime work of nurses, right? It's the system that can really play a huge part in mitigating or amplifying these feelings of stress and burnout. And like, is there a way to convey that in a way that might actually make people feel less than, right, in coming to people for help?
I think maybe I'd like to jump in there too. I think for this conversation, but globally for seeking mental health and the general population too, is there's a silver lining of COVID in that it was a shared trauma. A world pandemic is a shared trauma. We've all been through this. And so we saw our referrals skyrocket just to our department and our clinics because we were like, well, it's okay to seek help now because we've all been through this horrible situation. And so we have a right to seek help. This is what we should be doing. Everybody should be doing it. So I speak about that quite a bit and just saying we've all shared this. And now we have kind of this baseline crispiness of society. So we have our patients who come in and they're irritable before they even walk in the door. And so we have to deal with that as well. But then normalizing it, saying, hey, we just went through this horrible world problem. We need to figure this out together. So I'm just going to throw that, my 2 cents in there.
Well, I wanted to just comment about that, Karen, because we were seeing burnout in our system. I asked the psychiatry department, could you help us? And there was someone that her areas of expertise was resilience and stress and burnout and those things. And so she did a couple sessions with all the faculty. If you want to come, you come. If you don't, you don't. But at least we tried to do something. And I would not be on that Zoom call, as well as the other managers would not as well, to give them that opportunity to speak more freely. And we actually did it. We did one group for the medical staff and then one for the nursing staff. That was separate.
It's a question in the chat. And before I go to that, I think with expanding upon what we've all been talking about, what do we do if our chair isn't someone that's so thoughtful about this? If the departmental leadership doesn't always create this culture, how do we start to change departmental organizational culture to have these discussions if we are in smaller shops or places that aren't already beginning to discuss this more openly?
I actually think the smaller shops may have a mild advantage because you have less room for error in your workforce. I think the more and more that you see health system consolidation and growth, it's something that I think Lisa referenced very nicely. The hard part when you make it systemic is it can make people feel a bit of learned helplessness if you belong to a very large system. It's harder for people to conceptualize that they care about me on my third shift on Sundays or whatever it may be. So I think anytime, regardless of the size of your group, I think you can both play to the idea of humanity and taking care of your workforce. And if that's not what's going to work, if you don't have Dr. Zun running your show who's willing to do all these nice things, then there is a huge business case to be made for this too. And I'm not suggesting it's a dichotomy, it's one or the other. You can blend them. But there's a huge business case. The literature that has been referenced by my colleagues earlier is well invested in how much the topic of burnout and any related employee dissatisfaction is affecting these large companies. And so I think even if we come at it from that perspective, which has kind of been the evolution of burnout, right? First, it was, well, it's about you, the employee. You have to be more resilient. Well, that we know that's not the case. It's systemic. But then when it becomes systemic, you want people to feel like there's nothing that I can do, and trying to find a nuance between the two. But in a long answer to your very short question, I think there's a business case to be made at those facilities that there's never been a harder time to obtain a hardworking healthcare staff, particularly one that you can retain, promote, and grow from within to handle whatever these things may be over time, particularly in EM where it's a 24/7 staffing dynamic. You're not allowed to be a clinic who decides to close on Fridays and will just run shop Monday through Thursdays and take the fiscal hit. TALA does not allow that. So I think in that particular context, you have a business case to be made for, we need to address these immediately or we're going to start losing people. And we've never been a more well-connected workforce. I think it's another fallout from COVID that is really, I'm glad Karen brought that up, is we're all more connected and we're all talking to people we've never talked to from across the country. So if your small shop has a reputation for losing people due to poor conditions and poor this, it's probably not going to play very well in your recruitment efforts, or you're going to be forced to go the route of locums or agency, which are markedly more expensive over time.
Yeah, COVID is a really central and foundational thing that we can anchor to a little bit. We did a study using Twitter data as a data set, looking at how healthcare workers, we couldn't even parse it out between physicians and nurses, but how healthcare workers really viewed this idea of heroism as seriously detrimental, like as insulting, as don't add this on everything else, right? So the narrative that our workplaces and societies have tried to place on us has made it worse, right? Has made people either completely reject that or internalize it to the point where they're killing themselves. So there's a lot of stuff around COVID. I really like the idea that it gives people permission to seek help because God knows we're all completely traumatized and still are, right? But how there's a lot of interplay around COVID, that some of which is really good and some of it is really bad for healthcare workers.
Thank you. The next question I wanted to go to was LA's in the chat of how do we navigate the conversations around mental illness versus mental health? And he was saying that in some of his work that they've been doing, there's that resistance of people now feeling victimized if they do get labeled as having an illness or disease, which of course takes away from our whole intention of addressing the stigma.
I think the issue to answer this question about health versus illness is people can have lack of illness but not have health. The other problem people can just be almost like a zombie coming to work, doing the work, but that's really all you can really do. One of the areas where I think the stigma needs to be taken care of is really at the basic medical staff credentialing. That I still see credentialing applications where they ask about mental health in a way that really does not promote treatment. And that's slowly disappearing, but I'm still seeing those kinds of things. It's one thing, they'll say things like, someone will even ask, is there any kind of mental illness, rather than illness affecting their ability to work. But I think that's one level that really needs to be handled so that people aren't afraid of getting treatment, so that forever the next 50 years, they have to talk about their mental health treatment. And that's the same thing that happened with substance abuse, true. Once you get treatment, now you have to mention it over and over again. Whereas if you don't admit that you're an alcoholic, well, you can kind of ignore that fact. So I think we have to be able to look at these problems and be able to face them.
Thank you. I like this question that was posed. How do we support each other on shift if it's just us and it's busy and we want to keep our focus, but something is bothering us? It is one of those moments that it's not easy to push past what you're dealing with.
I can speak from a, oh, sorry.
Go ahead.
You
No,
go.
Tony, go ahead. You can go first.
I was going to say, I think similar to what Dr. Zun had referenced earlier, I think I can speak to this from a managerial component, that sometimes when people are in the middle of their shift, it's not the time they want to stop and talk about it, but you still note it. You make a note of it. You can tell this was a very complex thing. You had 2 pediatric codes followed by a domestic violence that went on for 6 hours past your shift end. I think that's something I try to catch people either at the end of their shift, or more often I have more success the next couple of days. I know that's not immediate, and maybe that's what I think the person asking the question may have been looking for, but I find that it means a lot to our staff to go back a couple days later and say, listen, I saw that Monday was real rough and we didn't really have time to chat about it. I didn't know if you wanted to grab a quick cup of coffee before your shift started, just so we can see how you're doing. I think it reminds our staff that it's not always the squeaky wheel. We care about them even after the trauma has passed. I think that very solid reach out goes a long way. And I think people are in a better place to talk about it than in the moment. I think in the moment's really hard, and some other people may have great ideas for that, but I have found that trying to get people to stop what they're doing kind of fights that idea of clinical need and clinical demand, that then just makes them more nervous to talk to you because they want to get back to work. But I think if we make a note of it and kind of keep a running list of who we want to check in with, I think it, and I've heard this from many people months after the fact, that meant a great deal. I didn't talk to you, but the fact that you remembered it and it was a week ago and you came to check on me, it just reminded me that people here still care. And I think that is a very important thing that we as leaders or managers of people need to promote.
I think that's a critical piece to give people like the rest of the shift to kind of manage it, because I know from what we know about nurses is that the first response is, well, I'm just going to work, right? Like you compartmentalize, you put it in a box, you put the box on a shelf. If somebody comes up and asks you to talk about it, now you got to take the box off the shelf and open it up again. And people just may not have the bandwidth, right? Or the emotional capacity to do that. So I think that your idea of checking in a few days later is just, it covers a lot of real estate, right?
I think something, I'll jump in, I'll put my EM hat on. So if I'm shift as an EM doc, there are times where one of your colleagues is really, they're in a room with a code and then there's something else happening and the radiologist happens to call, like I'll grab the phone, do it, take care of it, and then just kind of wait and catch them as they're coming out or have a moment and try and help out as I can as their colleague. Put my emergency psych hat on. So if I'm coming in and doing a consult and I know like our PDD is wild and super busy and some tough cases, I'll come and go, hey, I got this, we got this all taken care of. Don't worry about it. And just kind of helping and acknowledging that it's really busy. I get it. It's not, this is really stressful. And just sometimes even someone acknowledging that it's a tough day, I think is helpful. Just by that, someone said, okay, yeah, someone gets it. Okay. All right. So just some of the things that
I think there's some other things that we can think about. So do we provide, as leaders, do we provide our staff the skills to handle, there's something really bad happening in my personal life and I'm having a really bad shift? And is it worth having a staff meeting around that? Or could the leader say, and it depends what works for you, but what worked for me was to have a meal or to just take 5 minutes in the back and not have the continued bombardment of patients and issues and phone calls and those kind of things. And are there other things that we could do to help our providers in that situation, so they feel that it's okay if I have a bad day, it's okay to have downtime? Or maybe if you had a really long shift, to say, well, tomorrow, why don't you come? Do you want to come in a couple hours late tomorrow and get some sleep tonight? Things like that, that I'll agree sometimes it's on the spot and creative, but we've got to figure out how to support them. And I agree with everyone else that compliments go a very long way. The notice that your supervisor or director appreciated what you did is goes a long way.
I love it. I feel like I'm really hearing that moment from everyone that's spoken about this, whether it's acknowledging right then or a few days later or afterwards to your residents when you hear about the hard cases of but you maybe were in the weeds. Like, that's what it's reminding me of. You look like things were really tough, and whether it's that you took those phone calls and helped support, it's just these nice moments that seem to remind everyone they do belong in this emergency department, whether it's a tough time at home or on shift. And I think that's really a really lovely thought that everyone's addressing in some way, it seems like, at this time. I'm just making sure there's no questions that are coming up in the chat. I think another interesting question that was posed is, how do we even best utilize our family and friends and support systems outside of work? So whether it is work or the personal, leading to our mental health not feeling at its best at the moment, specifically if they can't understand some of the challenges of being an emergency physician, if they're not in medicine in any way. Another two-parter.
Well, we find, especially with nursing, and again, I'm pretty sure this translates pretty well because we're all sort of the same tribe, is that the only people who really understand what it's like are people who are doing it, right? And so family and friends are really useful, but you're kind of you're traumatizing them in a way when you tell, like, if you're in a group of colleagues, right, you can really describe exactly what happened and other people get it. If you try to describe it to people who don't do what we do, they're either like, oh my God, why would you do, like, that's a terrible job that you do, right? And they're like, okay, thank you. I don't need to hear any more about that, right? Because the things that we talk about, the things that make us upset are really upsetting. Like, the threshold for upset for us is like is really up here. So the things that we're describing to our family and friends, I think it's a limited shelf life, right? Like, you can only do that for so long. So what a lot of nurses talk about is they talk to their dogs, right? Like, just sit down with the dog and tell the dog what happened during the day. Finding these, either, like, if you can't get a group of colleagues, like finding almost a inanimate or non-verbal companion to tell them to, seem to help a lot, because it gets harder, right? If, like, the people you're trying to talk to are resisting hearing what you're telling them, then it becomes worse for us.
I fully agree. And I think COVID called that out incredibly so. I think there's a lot of people that work in our world that saw and had to do things and were part of some scenarios where we didn't want to tell our families. You didn't want them to either know about that component of things that happen that we take care of all the time, or to know of some of the difficulties you had with it. But that being said, I think the question is paramount. I'm just calling out the issue. I don't think it's necessarily always a good thing to go and let me tell you about my day. Instead, I think about, how do we stay involved with our family and our role within our families? And that doesn't mean you're going to ever completely cut it off and just say, well, I leave that completely at work and I don't think about it the minute I come home. Well, that's awesome. I hope somebody teaches me how to do that one day. The truth is, you will be thinking about it, but how do you still say, despite that and despite the difficult day, I'm going to go be, in my case, a father now. I'm going to go be a husband. I need to spend some time with my family and enjoy them despite the fact that this stuff happened. I think that's the hard part, is a lot of us, I think, will isolate or alienate. So then the family will say what's wrong, and you don't want to say anything to them, which I just kind of explained why. I think Lisa said it very nicely. I think it's one of those things where being transparent with them about what's bothering us isn't always going to be of the most assistance, but spending time with them and being there for them and still living that part of your life that is not tied into being a physician or a nurse in the emergency field, I think is very important.
Ted, I see you have your hand raised if you'd like to go ahead and ask your question.
Yeah, and I'm going to apologize, Amanda, but because you might get me after this meeting. But so I just came from giving a tour of our chaotic ED to the chief of staff of the governor of Pennsylvania. So, and it's someone who I've known for years from above the state level. But and I'll just say this: so are we ready to go to maybe ASAP or to our specialty? I'm convinced that we will always be emergency physicians, and we can't help ourselves. If an emergency patient, I think, comes into the ED, we're going to be obligated to see him. And as an example, I remember advocating for our women faculty who are incredibly dedicated in my department, and they tried to move our lactation room out of the ED into some obscure place upstairs in the hospital, and the women actually argued we can't do it. I mean, for a lot of reasons, I think we all supported this, and it was a great initiative. But but the woman said, we can't do this because we have, if we're on shift and I'm in the room, that they do, that they have lactation now is right smack in the middle of the ED. And they want it there because if a patient comes in and they're responsible, they want to be available to take care of that patient. That's how dedicated emergency physicians are, right? So we're not going to change. But it occurred to me, is it time to say that the US healthcare system is just not set up for us to be the safety net? Because in my emergency department, sometimes, and I'm looking at Les, I've known Les for a long time, and Amanda just joined us. It is the unsafety net. It is not a safety net. It is unsafe. And it's because for years we said, everybody come whenever you want and need into our emergency departments, and we will take care of you. I would submit that the US healthcare system is not set up for this. It is not. And in the moral injury that is resulting from our nurses and our docs and our residents and everybody having to take care of patients in ways that they're not trained to do it. And I just showed this chief of staff. We had, I don't know how many patients in hallways. We brought in nonstop by EMS. I mean, some sick, some not so sick, but I'm talking about the homelessness and the poverty and the substance use disorder and the mental health illness and all these other sorts of patients who really could be seen and taken care of in other places, and probably should be. And I'm just, I mean, we can't continue to absorb this the kind of volume in the healthcare system that clearly is not set up to be everybody, including primary care. I mean, I see more primary care patients than the primary care physicians do. And I see them past 3 o'clock because none of ours will. Don't quote me, I'll deny I said that, but I mean, 3 o'clock, 3:15, oh no, go to the emergency room. We aren't set up for this. So is this the message that emergency medicine wants to give to the world? And because I think the moral injury that's resulting of this, and that's what we're trying to do here, right, is explain the violence and the after effects and the moral injury. I'm not talking about the usual reasons why we'd have a debriefing in the past, right? So if you were part of a code and the patient was young and they passed away, or someone really resuscitated a lot, and it was devastating to the staff, that's what we do. I'm talking about all the other factors that contribute to what I think is an untenable environment. And I'll shut up, and I apologize, Amanda.
No, I appreciate your sharing. I think all of this is important because I think it just brings us back to how do we advocate for ourselves? Because I think, Ted, what you're sharing of what you see for the department and when the patients are languishing there too with boarding, as we all feel that in emergency medicine, is how do we still be able to handle caring for our patients as best as possible in those circumstances, even when we're going out to waiting rooms and dealing with hallway beds and their anger. But how do we also still care for ourselves in those moments and allow ourselves in such ways to not only care for ourselves in our mental health, but to get and take those breaks truly away from the department. And it was leading me towards the question I wanted to ask this panel of how, even in those moments that are bad when we know it, but also we have, I think this is almost ironic to say now, how do we practice preventative care? Because we know we all deal with these things, and whether we think we don't need help or we do, I think everyone, as was said earlier, needs to be speaking to someone. So how do we start to get our colleagues to agree to that idea, or not forcing people's hands, but how do we make this a more normal thing in those bad moments and in the moments where we think we're fine?
I think this has to really start with pre-licensure education, right? So I think after I really dug into this secondary traumatic stress study, I realized that like nobody ever talks to nursing students about the trauma, right? And I feel like maybe this is part of physician education too. Like well, you're going to go in and you're going to do good and everybody's going to be so happy to see you. And then the first patient who throws a chair at your face, you're like, wow, wait a minute, I did not sign up for this. But nobody talks about the emotional trauma of the work, right? And how to give people at the very beginning of their careers the understanding, like, this is the world that you're walking into. It is traumatic. It is normal. to be affected by what you're going to see and what you're going to do. And let's talk about some ways that you can manage that and still remain intact, right? Emotionally and morally intact as you go about this work. But it has to start like at the very beginning, right? Like we can't spring this on people when they bump into it a couple of years into their careers, right? I think it really, the way that we normalize this is we start teaching students about it.
I think that's a very good point. I know we, as our psychiatry team, we have our faculty go in and talk to the first year medical students and say exactly that. You're here, this is something you've been working very hard for, but it's going to be hard. What do you have as your backup? Like, what are your things you turn to? And so we do that, but then all the way through their clinical years as well, reminding of that and also being there as mentors and really encouraging people early on, find a mentor. I've had a mentor since 1999, and she has been through my whole career with me and amazing. So finding someone who has found that way to themselves be resilient in medicine, and in that way guide the medical students all through school, all through residency. I really think that's key, is finding a mentor and really figuring out how do they navigate it and having someone that you can go to. So I agree, starting early is key.
Yeah, I think as an organization, what's also really important is to realize that trainees are exquisitely sensitive to these struggles, and what they choose every year varies wildly based upon their clinical experiences. Certain years, certain specialties are very sought after, then they're not sought after. And I think a lot of it is really how things are handled. I know emergency medicine is going through a real crisis right now in terms of the match issue. I think the trainees are aware of the stressors. So I think that you're now having a problem of even less people going into the field rather than more. And I think that's happening just in general in medicine, that people are gravitating toward these fields that are less stressful. And it's no wonder everybody comes in wanting to be a primary care doctor, then they end up wanting to be an ophthalmologist or a dermatologist. So I think we need to somehow fix the organizational problems. Otherwise, market forces will really make for a very lopsided healthcare environment.
I like all the comments about therapy and trying to get things started as early as the trainee level. I think another option, in case, and it's obviously coming from a psychiatrist, people have a very strong feeling to the word therapy. Another thing is just to normalize sharing of information with peers. And the irony is we've been doing this forever. It's unstructured. It's called going out after work, right? We already get together with people and we talk about things in a non-work environment. And whether we know it or not, we're doing that not just for friendliness. And so we're doing this to cope, that we are engaging in helpful catharsis and normal processing, and actually very mature way to handle stressful situations. So if you are from a smaller group or don't have groups that do that on a regular basis, I think having something structured from the department that isn't listed as necessarily therapy, but like, hey, we have these things Friday afternoons or Monday evenings or whatever, we all get together, we switch it at different people's houses and we chat. Now, in a 24/7 service, you're never going to capture everybody all at once because people got to be at work. But this does seem to work. And they don't have to be formal. And I like how everybody mentioned you need to start this when it's not a crisis. Because if you're only doing it ad hoc in relation to a crisis, not only does it seem to lack in sincerity, they often don't work as well. And so you really want them to kind of be dug into the everyday actions, every week actions, anything with peer support groups. You can call that whatever you want to call it. You can call it going out for drinks, getting dinner, a book club, however you want to formalize it and put it on campus or off campus, and not necessarily make it mandatory, but try to, if you're a leader, get a nice majority of people going. It's a nice way to onboard new folks too, so they feel more comfortable with the policies and procedures. I think if everybody wanted to do therapy, that'd be great. But for those that don't, I think this is a nice option that you can build into your operations, so it doesn't feel like we're picking on you, the staff, but this is something that everybody does, and it really helps us all kind of do our job better and serve those who we serve more optimally.
So I think all your comments are well served by, do we teach the skills and abilities to handle these things starting in medical school? Do we teach resilience and wellness? Do we have them practice it? Do we provide the opportunities for them to determine what works best for them? And I think, Tony, you mentioned a great idea, and I think For some people that works, maybe therapy for others, maybe talking to the dog might be the way that works for them. But we should give them a toolbox saying, here are options that you can utilize when you're feeling stressed out, and figure out which one's going to work for you and develop that. And so we as leaders need to provide that foundation for them, or that structure like you were talking about, Tony.
I really like that this was not one of the pros questions, but the thought that I had while you said that was, do we even ever, and bear with me, do we ever normalize the idea of what if you're really doing so poorly with your mental health that that's why you need to call Jeopardy? Like we always say, if you're ill and really dealing with an illness, but why can't it be if that day your mental health is that illness and what's not well about you? I say that with, I know the caveat of chairs are on here and it's hard to staff already, let alone if Jeopardy is being used. But is that a way that we start to give a toolbox and normalize that it's okay to think about our mental health and to be working on it as part of ourselves?
I've had some faculty say, I'm going to take a mental health day. I'm like, great. Okay, let's see if we can find someone else to work. It'd be like any other sick call. You've got to be able to handle that situation as a leader. But I think that we're very comfortable saying, oh, I have the flu, I have COVID, I have whatever, but I'm not comfortable saying I'm having a mental health crisis and I need today off or tomorrow or whatever.
Another question I had while we were talking, Tony, when you were talking about these informal get-togethers, which I agree, I wouldn't have gotten through residency without that ability to understand my shift and what I've gone through with my co-residents and the attendings that would come out with us afterwards and the nursing team. It was so amazing. But is there a way that we should be formalizing and training people to be specific peer supporters, to be something more formalized than that? Is there a ton of evidence that people would use it, that it could help us?
Yeah, I definitely think you have backing for it working. I think the one thing that's a little bit interesting, I would say the pain point in that plan is training people to do it and having some degree of an and by pain point, I just mean something we'd have to address. Not that it's not doable. I think Lisa and Karen both referenced this a tad kind of in their overall education. If we start this early on and we make it seem like this is something that doctors just do, and we do it. It's also where the whole mentor thing started. It just started with, you pick somebody that was much further along typically in your career because the assumption was they would be able to assist you better because they've been through so much more. We've been doing this for a while. So I think probably it would depend upon whether this is organically happening in your organization or not. If it is, I wouldn't mess with it. But if you're trying to get it off the ground, I think some expectation and training programs, we've seen it a long time. I would argue, I think we have some chief residents on this call. I think chief residents serve as peer supports whether they know it or not. It's kind of built into the idea of this administrative clinical bridge. And so finding other, say, PGY 3s and 4s, more senior people, and saying, hey, are you already doing this? If you're not, can I give you some skills on how to do it? And I think a big take home for it is we're not asking you to have the answers. I think one of the best things that happens in peer-to-peer situations is to look at somebody and have them look back at you and say, yeah, I feel just as lost as you do. It's not magical pixie dust. There's no special answer. And that's not learned helplessness. That's alignment. That's solidarity. That's understanding that this is a really rough job and it's okay sometimes to not have the answers. And I think just kind of getting our people open to saying that, if that comes through a training component, Amanda, I'm all for it. I think the key would be when some people don't want to do it, how we address those. I probably wouldn't be quite as mandatory on it, but I think encouraging everybody to do it in some context would be very useful.
I love that. I really love the blending that I keep hearing of like the operations to keep an emergency department going from leadership and whoever are those leaders, whether it's the resident leaders or some of the attending with these roles, to kind of help continue to create that environment and show that unfortunately it's not just our role to take care of our patients, but to check in on each other is probably something that we think of as a unnamed role that you guys are stating over and over. And it's truly, I think, sounds lovely, but it's an interesting way that I don't think we speak of often when we think of our profession.
Yeah, I can mention one thing that our organization has started to do, which I think has been useful. If you look at mindfulness, it's one of those things which sounds quite easy, but very difficult to do. And they started this monthly mindfulness that's done by a number of faculty and staff, and they kind of rotate this. And I've gone to a number of these where you realize that you actually learn something, and it's a fairly neutral way of doing it. It's done through Zoom. It's purely voluntary, but I think that's a kind of a skill that we can all learn. We can all learn how to do it better, and it's not that time consuming. I mean, initially, I think this had the sort of the stigma of, oh, this is kind of fruity kind of thing. But I think more and more, there's a lot of data about how effective it is. It doesn't take a whole lot of time. And I think it's a kind of a micro skill that I think people can learn.
I agree. And I don't know if you saw LA's comment. He was saying Dr. Hirsch always leads us through our essay of wellness committee. She starts with mindfulness. And I was at a loss when she wasn't there when I had to lead it, because I am not as great at practicing mindfulness as she is. So it is a hard skill to practice. We're getting down to the last 10 minutes of this. So I really want to encourage, if there are other questions that people want to ask, that they feel free. But I also just wanted to bring it back to the very general question to hear from each of you of how can we really, like, what would you suggest is our best way to start advocating as an individual for our peers and ourselves in our emergency departments to help with our mental health? What you would say is the one takeaway you'd want us to come away with?
I feel like it has to be a collective effort, right? It's a team effort. And I think when we present information, right? Like, we're information junkies, right? If we present information to our colleagues, like, look, this is how normal this is. This is what we're seeing in our colleagues. This is the rate of suicide among emergency medicine physicians and nurses, right? This is unacceptable. And we as a team are going to make this better. And these are some things that we want to do, right? So it's introduced as everybody is subject to this, right? To varying degrees. We see it as a collective problem for our community, and here are some things that we want to do together to make it better.
I like that. I would also add that I think a lot of EM professionals are so amazingly dedicated. I think a lot of this is about we're doing our best to try to fix something, and we care about you. And I know that can come off as glib, or God forbid a shrink is saying it, so it comes off very shrinky. But the truth is, I think there's so much that people will work very, very hard for a mission, and they'll work very, very hard for good leaders if they know that you care about them and that you are trying your best to make things better. I think there's nothing worse than kind of the absolute, well, this is the way it is, so just deal with it or don't. I think that's a very dangerous dichotomy for the people that we care about and that we serve. So to me, I always take it back. That'd be my take home, is anybody you're working with, I think, to make all of these things we've talked about kind of manifest themselves, is you start with culture, because culture will eat process, and we can process the heck out of this. And if the culture ain't there, it's not going to work. So if you can get a culture of caring where everybody's willing to talk about this stuff and not be held liable for it, I think the rest operationally can start to play themselves out. It's my 2 cents.
I think I'll jump in. And I think one thing that I found and is very helpful is find a seat at the table in the C-suite. So I think it's great when you bring somebody down to the ED and they see it when you're on diversion or whatever, you're trying to figure things out. But if you're in the C-suite and you're sitting there in a meeting the morning after maybe you worked a late shift, and someone who's non-clinical may bring something up, you can stop and go, well, I'm just going to tell you what happened last night when I was working, and this is how I see a path forward. So remaining solution focused when you're at that table. I think we have a tendency to say the system is harsh, this is what they're doing, really going in there and saying, okay, we do have a problem. I just experienced this, and I've experienced this the last 5 shifts or whatever, and I know colleagues are experiencing this as well. But here's what I think could make it better, and here's what I would like to bring to help make it better, and what can we do to lead through this? So I think that is something I found to be very helpful, and that constant reminder.
Yeah, the issue with these C-suite is always, my experience has always been somewhat mixed with them, especially when they're physicians who are in the C-suite. That I've dealt with a number, some of whom actually were in emergency medicine. Once they go there, they sort of forget what the world was like. And some of them will even do shifts. And when they are aware of what the person on the street has to deal with. But then once they go back to the C-suite, all they talk about is length of stay and throughput and all these kind of buzzwords. So I think it's always a struggle, is how do you not become what you're supposed to be doing in terms of your task, and how do you work with those people? But I do agree that you have to have a seat on the table, though. Yeah, otherwise you don't have a chance.
Well, I'm going to take a little different tact to my closing words. I think we need to reinforce it is okay to take care of yourself. And we're so focused as emergency docs, emergency psychiatrists to take care of that patient and dedicated and committed. And if I need to stay another hour or two to finish the cases, I'll do that. But is it okay for me to take care of myself, to take a vacation, to take time off, to turn off the emails and the phone and all that? So I think that part of this is reinforcing good coping mechanisms and have your faculty or your friends or colleagues. It's okay to take care of yourself, to get therapy, to go to mindfulness, to do the things that are going to work for you.
I cannot thank you all enough for dedicating your time, and for those of you that came for this hour. I think all of this, I just love like listening to the advice that you all have, because I agree. Bringing it back to normalizing how we can take care of ourselves, whether it's putting up those away messages when you're on vacation, or that you'll respond during normal work hours and when it's not a weekend. Normalizing all these moments of boundary setting to care for our own selves, I think is so huge. And I think getting to hear that from experts in the field that are helping lead departments is so huge. So again, thank you for your time. Thank you everyone for helping kick off Stop the Stigma EM with this first event. And please continue to send us your questions, be supporters. I cannot thank you enough. This was truly a wonderful hour. And I love that culture will lead to process too for a while. Thank you,
Thanks,
everyone.
everybody.
Thank you. Appreciate it.
What a great way to start Stop the Stigma EM month. So thanks a lot. And thanks, Dr. Deutsch, for leading this.
Thank you so much.
Everybody gets 3 minutes back so you can go to the bathroom and go to your next meeting. And that is okay.
Take your time. Take an extra minute. Get the good toilet paper. Bye-bye.
Bye.
Bye, everyone. So good to see all of you.
Yes. Dawood, thank you so much. You were wonderful and great to see everybody here. Amanda, Emily, it was so
Amanda,
great.
you did an amazing job.
I know, I was texting her. It was really cool.
Amazing. I was
Oh my
like, oh
goodness.